This is an educational podcast on shoulder pain being brought to you by the collaboration between EUSSER and ESSET, the European and American Societies of Shoulder and Elbow Rehabilitation. Today, the primary moderator will be
Ali Narani,
a representative from EUSSER, and Kelly Bliven, a representative from ESSET. The first part of this podcast is going to address the question, what is the pathology? The participants answering questions on this topic are Ian Horsley and Lori Mishner. Lori Mishner is the director of the Clinical Biomechanics and Orthopedic Outcomes Research Laboratory. Dr. Mishner's research characterizes the biomechanics of musculoskeletal shoulder pain, diagnosis and treatment of shoulder and cervical pain, clinical trials investigating optimal treatment strategies for shoulder and cervical disorders, and the use of patient-rated outcomes measurement tools to assess health-related quality of life. As the director of the core, she directs and develops collection and analysis of patient-rated outcomes and the process of care in the USC Physical Therapy Associates clinics, and serves as a resource for clinical research. Dr. Ian Horsley of EUSSER is the regional lead physio for English Institute of Sport and Upper Limb Lead. He just returned from the Olympic Games as a member of the Team GB headquarters medical team. He just returned from the Olympic Games as the member of Team Great Britain headquarters medical team. His doctorate is investigating modifiable causes of shoulder injury in professional rugby players, and his current research interests within the English Institute of Sport are devising improved functional screening for sporting shoulders and sport-specific rehabilitation for shoulders. The second part of this podcast is going to address how do we treat the pathology. The participants of this section answering questions will be Owen O'Connor and Mike Schaefer. Owen is a specialist shoulder physiotherapy working as clinical director at Evidence-Based Therapy Centre in Galway in the west of Ireland. He has previously worked in a range of settings including large UK teaching hospitals and elite and sub-elite sport. He developed his shoulder specialization working with an extended scope practitioner in the NHS in London. His main clinical and research interests include rotator cuff dysfunction, frozen shoulder, and chronic persistent pain. Mike Schaefer is a physical therapist and athletic trainer and is the clinical supervisor for physical therapy at the University of Iowa Sports Medicine Center. He maintains a clinical practice as well as teaching in the athletic training curriculum and serving as an adjunct instructor in the physical therapy education program. Mike's professional interests include clinical decision-making and neuromuscular control of shoulder instability. Our third and final section is going to address how we assess Our third and final portion of this podcast is going to address the question, how do we assess the efficacy of the treatment? Our participants in this section are Joe Gibson and Chuck Thigpen. Joe Gibson is a clinical physiotherapy specialist at the Liverpool Upper Limb Unit and a consultant physiotherapist in private practice. She lectures nationally and internationally about assessment and rehabilitation of the shoulder complex and is a consultant to several elite sports teams regarding shoulder rehabilitation. Jo is also an adjunct lecturer at Liverpool University. Her research and special interests are communication, complex instability and pain, accelerated rehabilitation, and the role of the kinetic chain in rehabilitation. Chuck Thigpen is the director of Observational Clinical Research and Orthopedics Center for Effectiveness Research in Orthopedics and Research Scientist. Chuck Chuck Thigpen is the Director of Observational Research in Orthopedics, Center for Effectiveness Research in Orthopedics, and a research scientist for ATI Physical Therapy. His interests include non-operative treatment of shoulder pain, optimizing post-operative outcomes, and the throwing shoulder. Now we will move on to the podcast and answering these questions with these individuals.
So we're going to start with part one of this podcast, which is to discuss what exactly is the pathology in shoulder pain. And I'm going to ask Ian Horsley and Laurie Michener to answer these questions. So Ian, if you don't mind answering the first question, is can you please describe the primary population that you treat in your practice?
So I work in elite sport. So I work for the English Institute of Sport, and so I have a specialist population of athletes, and I am responsible for the management of most of our overhead athletes. So the pathologies that I see are mainly related to overuse. So within the swimmers, so we get quite a little bit of tendinopathy related to the overuse and fatigue elements of swimming, and then we get a fair number of instability, varying from micro instability but to complete dislocation from sports like rugby, weightlifting, cycling, road cycling from the crashes, and canoeing.
Fantastic. Laurie, may I ask you to answer the same question as well?
I work at the University of Southern California in Los Angeles, and the majority of my position is researcher and educator, and so I have about 10% of my time that I see patients. The patients that I see are probably divided by about 50% shoulder, and the rest are mixed up low back, neck, and a variety of other things. Patients I see with respect to shoulder, there can be high-level sports, professional baseball team, for example, or I see status post-rotator cuff injury, or I see somebody with a long thoracic nerve injury, wide variety.
Excellent. Well, thank you both. Can I ask you how common is shoulder pain in your population? And what diagnosis is most common under this pathology? If I may ask Laurie Michener to answer that question first, please.
Sure. So the statistics say that shoulder pain is about the second or third most common musculoskeletal condition behind spine pain, and predominantly that is low back. And in the outpatient center where I work, that's probably about the same that we see. We might see a little bit more heavily oriented towards shoulder because there's a couple people who are shoulder specialists in the clinic. And the most common of the shoulder conditions, if I can use the term subacromial pain syndrome, whatever that may indicate to each folks, I think that to mean people who have rotator cuff problems, to people who also have bursitis in that subacromial area. You could even extend it to mean people with biceps tendinopathy and potentially interarticular things like labral tear that could also be provocative when you do tests for subacromial pain syndrome. And so if that is the umbrella term, that clearly is the most common shoulder pathology / diagnosis.
Fantastic. And Ian, can I just ask you, your population seems to be perhaps more younger and more sporty than most people's population. You think shoulder pain is also fairly common in your practice or less so?
I think within the whole institute, if we look across all the sport, we know that that shoulder problem, shoulder pain is the second most prevalent area for injuries following the knee from sports. And certainly because of the nature of a lot of the sports that we have, overhead sports, so we've got swimming and then challenging sports like athletics with javelin, discus shot and pole vault. So that there's a lot of force going into the overhead position. Then from a swimming point of view, they're averaging about 16,000 revolutions a day in the shoulder. And not forgetting that within my population, and we also look after the Paralympians as well, which is adds another problem. So we have a musculoskeletal problem superimposed on something like a neurological problem with, say, a lot of our swimmers have got cerebral palsy, which makes rehabilitation and the diagnosis quite challenging. But if I had to sort of group the mechanism, probably the most prevalent mechanism would be impingement related, and it would be subacromial pain syndrome, but more likely towards some tendon irritation with a little bit of bursal irritation as well.
Fantastic. Can I ask you, do you see biceps pain being more prevalent in your population as well?
Compared to what I see in private practice, yes, certainly long-headed biceps, we do see a higher number of those.
Fantastic. Now, can I ask you, Ian, next? Do you use any algorithm or any method to classify shoulder pain patients that you treat? And if you do, then what is it? And if you don't, then why not?
The basis that I use is based on Jeremy Lewis's shoulder symptom modification procedure. And one of the reasons that I use that is because when we look at sportsmen, at overhead athletes, they have specific movement patterns which are necessary for them to be able to complete and compete successfully in their sport, which may not be the optimal position for if you weren't playing sport. So in let's say, for example, in judo, one of the ways that you engage and hold on to your opponent is flexion and full internal rotation, which sort of goes against the biomechanics of going into elevation with external rotation. Now, that's just a component of being successful at the sport. So we've got an increased capacity for injury there. And we have to try and manage things around that. And so by being able to use modification procedure, and it mainly relates to what's happening, looking around posterior tilt, lack of scapular upward rotation. But then integrating into that, looking at the different components of the kinetic chain, because we tend to find, and certainly in a lot of our throwers who develop shoulder and elbow pathology, that their problem originates from around their pelvis and often lack of stability through the pelvis. So locally, sort of shoulder symptom modification procedure, and then globally assessing the contribution of the trunk and the lower limbs and pelvis to the mechanics of the shoulder.
Thank you. Laurie, can I ask you the same question? Do you have an algorithm or method to classify shoulder pain in the patients you treat?
The algorithm I use, I diagnose people with respect to pathology, because I think pathology does help to guide some elements of treatment. So my first step is really determining if there's a pathology present through some clinical exam, and or potentially there may be imaging that may confirm that. Second, then I'm looking at impairments that the patient presents with, which exactly as Ian said, symptom modification procedures clearly are part of that, and looking at trunk with respect to impairments and how that relates to that. And so identifying the key impairments with that patient that's in front of you, and also their level of irritability. How irritable are they? So how intense can my rehabilitation be? And what are the approaches that I'm taking at this point if they're high or low irritability, for example? In that algorithm, also I think critically looking at psychosocial factors as well, and things I think we'll talk about in the next question with patient preference as well.
Fantastic. Well, that's very useful. It kind of leads to the next question. And if you have anything to add on that, what is your general approach to evaluating and approaching a patient? I know you have answered that kind of question already, but do you have anything else to add?
So key things I think that are critical for diagnosing the pathology. Two things to remember. One, we're treating the patient and not the scan. And so we may see something in a scan, but if my clinical exam can't reproduce the pain in that patient, and focusing on some pathology or pathologies, the scan isn't the number one thing. Two, using a few tests as possible so we're not susceptible to false positives, because we all know who are on this podcast that seems to be now hundreds of tests for shoulder pain, and trying to do all of those obviously is the wrong approach. Second is really look at those impairments and irritability, as I talked about before, and then this key aspects of talking with the patient, sorting out their functional level by a multitude of measures. It can be a self-report outcome measure or patient-rated measure, but also asking them specific questions about what they want to do, how satisfied are they with their shoulder performance, how acceptable these symptoms are. For some of us, we think that it makes sense that they have pretty good function. They're a 72-year-old. Obviously, they're very satisfied, and they tell you they're not. So really asking from a multitude of perspectives.
Thank you, Laurie. May I ask Ian the same question as well? What is your general approach to evaluating and approaching a patient with shoulder pain?
So it will change varying on where we are in the competition cycle. So there's never a good time to get injured when you're a sportsman. And the next event, the next games, if you listen to coaches, is the most important. To do is we want a fully functioning athlete, and they need to be able to optimal perform their sport to the best of their ability. And a good example was while I was out in Rio in the semi-final of the women's hockey. We had quite a bad shoulder injury, which I saw the day after, and the athlete was unable to lift their arm up above the head due to pain levels exceeding 8 out of 10. We assessed that the patient had an ultrasound scan, and we couldn't find any major pathology around there, and we were able to rehabilitate them within 24 hours below the horizontal, because in hockey your arm never goes above the horizontal. If your stick goes above shoulder height, it's a penalty. And she was able to, not only did she compete in the final, she scored a goal in the final and ultimately won a gold medal. And then we have continued to address the shoulder for normal function. But ideally, we want to evaluate the cascade that led to that injury. So with most things, if it's related to trauma, say if it's a rugby player and it's from a tackle, that's quite easy to legislate what happened. But if it's an insidious, then we need to look at the training, and what tends to happen is that the volume of training gets changed abnormally. And the work that sort of Tim Gabbett's done recently about monitoring load, the weekly average load versus the monthly average load, and knowing that if you get a ratio of greater than 1.5 weekly over the monthly load, then you can get a 3 times greater incidence of injury. So we try and get the coaches to monitor the load, and if we look for spikes in training that may have caused that injury, if we've had a change of technique, if we've had a change of equipment. So we look at with the insidious ones, we try and look holistically. And then there's, as Laurie was saying, there's sort of psychosocial factors, the pressure of the games, because again, for our athletes, it's about funding, and winning medals means that they get funding and they can compete in their job, and getting that balance really.
Thank you, Ian. Now, may I ask you to answer the next question as well? And this is something that is fairly close to my heart as well. We see a lot of patients who come with imaging showing, certain pathology on a scan, and that does not correlate necessarily with clinical presentation. And I have my views on it, which I will share in a moment. But can I ask your views on how do you reconcile the differences in the diagnostic scan results and the clinical presentation, i.e. the symptoms and signs the patient presents with?
We know, let's say for rotator cuff tears, that as you older, traumatic, rotator cuff tear, so about, in your 50s, there's about a 13% chance going up into your 80s where you'll have about a 50% chance of having an ACE. So we will examine our patient. We will look at what their functional movement is like. One of the things that I talk to patients about, Joanne Elphiston knew, that optimal muscle recruit patterns gives you beautiful, effortless movement. And that's what we're trying to look for. So if somebody's obviously overworking, straining to do something, we'll work to try and down-regulate that. Certainly I try and get them to move as they want to move. I think a lot of the time we make all movement patterns fit for one. So this is how you move your shoulder into abduction. Everybody does it. We know to keep healthy, there are tiny inherent movement changes and variability. If we can, in a session, by giving them some coaching about how to move, or a little bit of facilitation by poking a muscle or inhibiting a muscle, I can change their functional pain. We can say, yes, your scan shows that you have got a tear, but I haven't done anything to your tear and your pain level's getting better. So let's see if we can move you better. Okay, move you smoothly, get this beautiful movement, and we'll see what happens with your movement. Because at the end of the day, as I say, you came here, you didn't come in to see your doctor saying, I have got a rotator cuff tear. You said, I get pain when I do X, or I can no longer do X. Okay, and when you go away from here, you can move painfully after I've treated you for, let's say, 3 weeks, and we scan your shoulder again, it'll look exactly the same as when you came in. So trying to get them away from this correlation that pain equals damage, and also that when the pain has gone away, that damage is still there. So we need to make sure that once their pain's gone away, that they don't have an aberrant getting re-injured, if that makes sense.
It does, thank you, Ian. Laurie, can I ask you the same question? How do you reconcile the differences in diagnostic scan results from the clinical presentation?
I think about the scan tells us what's there, but not necessarily if that's the cause of their pain. And so I really depend on the clinical presentation, because I think about treating the person, not the scan. And so I think a perfect example of this is asymptomatic rotator cuff tears that was kind of alluded to prior with Ian. Lots of people have tears, but they may have pain, and it's not even related to their rotator cuff tear. But I think labral tears are a perfect example. Type 1 fraying labral tear, and they likely aren't related to most people's pain. And so I treat the person, not the scan.
Thank you. In my practice, I haven't seen a rugby player who's played rugby all his life who hasn't got a labral tear.
Right.
But they almost never have a symptomatic pain from the labral injury. Mm-hmm. And they usually present with something else. And, I try really hard to convince my other colleagues that to treat the symptoms and sign the patient presents with and not necessarily the scan. But it's sometimes harder with surgeons than physios. Anyway, can I just open this up to the rest of the group to see if they have anything to add on the pathology of shoulder pain?
I have a question about how many of you have patients referred to you in which they come with shoulder pain as the diagnosis instead of a more definitive diagnosis that they may get on a scan. What is the frequency you get that?
I think it depends on where you work. For me, it's pretty common to get a referral at least 50% of the time it says shoulder pain. And they're referring it to people who see a lot of shoulder pain, so I think they might feel comfortable doing that and only put on things like exclusion, but they're not clear sometimes. But the other part of the time, easily I will. And that's excluding post-ops.
Yeah, certainly in our practice, the athletes come directly to physiotherapy, so they all come in with shoulder pain. There's no imaging done, and then if imaging is to be done, it's done subsequently. And generally, it's to exclude things rather than include things, because with our athletes, there are all sorts of things wrong with them anyway if you start imaging them. So we try and hold back on imaging. Or we have a specific thing that we want reported on. So have they got this? We're not bothered about other things that might confound the athlete, start worrying about things that don't fit in with their presentation.
I want to really thank Laurie and Ian for sharing all of this. Are any of you who were not answering these questions directly, do you perceive or approach this pathology differently, or do you see a different type of patient population that is unique to what has already been described?
Well, most of my population are self-referrers, and I would say that because of the area that I live in, Galway, which is a kind of a med tech hub where a lot of people work on conveyor belts and look down microscopes a lot of the time, I do get a lot of people self-referring with shoulder and arm pain that isn't necessarily due to their rotator cuff or a frozen shoulder, the typical things. So I probably see a population with more nervous system activity, sensitization, and other factors, mixed factors, psychosocial factors, work-related issues, I suppose. And I suppose therefore my screening assessments would often include kind of, tests to test for neural sensitivity, or screening questionnaires like Pain Detect or SLAN's neuropathic pain questionnaire. So I suppose that is perhaps a more unique population that I'm seeing, I suppose. But yeah, I would always include that in my algorithm for how I categorize patients. So what component is a structural problem with the shoulder, with the rotator cuff, and what component is central nervous system sensitization.
Thank you. Joe, you were going to share something.
Only that we're sort of a tertiary referral unit, so we get a lot of the complex pain and as Owen's saying, in terms of sort of the more neuropathic related and centralized pain, but also a lot of complex instability. So they sort of come with their own challenges, but I would say that there is a big psychosocial element with some of those patients, certainly, and some very specific movement disorders. But in terms of how we approach the treatment, I think other than perhaps that group that Owen's talking about, I think what Laurie and Ian have said in terms of, is it stiff, is it irritable, but can I change it? And being mindful. And I think one of the things perhaps I would just emphasize that I think they've both mentioned is I think the evidence is fairly clear that sort of 70% of our decision making is from that subjective assessment, and actually our objective is really our confirmation. So our objective assessment can be very simple if our subjective assessment is very thorough. And I loved what they were saying about listening to the patient and their perspective, because if you let them tell the story, they will give you the information. And I think the only other thing I'd like to pick up was about what we talked about scans at the end. Is a lot of the research now is just showing the importance of how we massively underestimate the impact of language. And I was teaching at a rugby club yesterday, perfect example. Player had been told they just got degenerative changes, so the doctor thought they'd reassured them. The patient, my career's over, I've got degenerative changes. And I think some of the work that's coming out about the language we use and that we see as very straightforward and reassuring for a patient can be quite catastrophic and have a lot of fear association. So there's a big move to use terms like, normal age-related changes, or like Ali said, I love that, you've played rugby all your life, what do you expect? This is normal adaptation, and contextualizing it for patients. So I think that's something we need to be very mindful of.
Yeah, I just build on what Joe said, and that the ability of change over time, not just in a single session, but can patients see a change over time? And so if 70% of patients are going to change, I may not can change it today, especially if they have other psychosocial issues or other overlying cervical issues, then it may take time to unfold those things over 3 or 4 weeks. But over that time, I expect those patients to improve.
Perfect. I think with that note, if there's nothing else to add, we should move on to the next section. So the next part is, how do we treat the pathology? And I'm going to ask Owen and as well as Mike to answer these questions. So Owen, start with you. What proportion of patients are essentially post-operative rehab versus primary physical therapy for shoulder pain in your practice?
In my practice, I see very few post-op, really. It's probably less than 10% of my practice is post-op rehabilitation. So certainly around 90% would be referrals with primary shoulder pain.
And Mike, can you answer the same question for us?
Yeah, probably about 10 to 15% post-operative and 85% non-operative.
Fantastic. Now, is active exercise therapy the main intervention? And if so, where do you begin? And what are your short-term aims of the treatment? And finally, what guiding principles do you use and find most helpful in progressing a shoulder patient's exercise program?
I suppose ostensibly exercise therapy is my primary modus operandi for treating patients. But really, where do I start? If someone was to ask me what's the most useful piece of kit that you use in your practice, it is probably my whiteboard. because, I think it's made such a huge difference to my practice, where I've actually now spent much more time explaining to the patient the findings of the examination, what the diagnosis is, what the contributing factors are, and really outlining a treatment program for them. And most importantly, I suppose, getting them to opt in to the idea of rehabilitation, discussing what the treatment options are. Broadly speaking, more conservative treatment like rehabilitation and exercise versus corticosteroid injection perhaps versus surgical consultation. And really actually trying to get them to make that decision that, no, I want to do this. I want to go for rehabilitation. I want to try and do something more conservative first to get myself better. And I think, that unpicking all of that with a patient and getting a kind of a verbal contract with them will be always where I start. And trying to give them some sort of realistic time frame around, okay, what are we going to expect here? How soon it benefit? 2 to 4 weeks perhaps. I would certainly expect significant benefit at 6 weeks, but we need to push on towards 12 weeks and possibly beyond. So, setting realistic expectations and goal setting. And then really sort of breaking down the treatment plan and thinking about, what their goals are and how we're going to achieve those goals through usually rehabilitation exercises. So that would broadly be my starting point. I suppose really want to get the patient on board, you want to start getting some pain relief for them. So, gentle exercises, incremental exercises, and as Ian has talked about, particularly with, rotator cuff and tendinopathy problems, we really need to talk about load management, and not just load management of their actual exercises, but load management of all of their activities, and being very, very clear about that. So I see a lot of multi-sport athletes, triathletes, exercise addicts, who really have to, be very clear with them that, we need to reduce the load on this tendon to then build it up very incrementally towards the activities that you want to be doing. So perhaps isometric exercise or inferior cuff type exercises that will usually not be provocative of their pain, and building up towards functional rehabilitation. I suppose, coming back to my earlier point about the nervous system, I always do have it in the back of my mind. And, I think sometimes a lot of what I'm doing in my practice is, rather than strengthening their rotator cuff or strengthening their scapular muscles, is perhaps I'm just doing graded exposure, so reducing their load, reducing their pain levels, and then building them up very gradually towards those activities that were very painful. So I may be doing some strengthening, but I may be doing graded exposure to movement and, reducing the sensitivity in the nervous system. I'm not really sure. Perhaps some of the other members of the team might have thoughts on that.
Mike, can I ask you to answer that question as well, please?
Yeah, can I just say I agree with everything you said? Would that be fair?
Yeah, it would be fair, yeah. If there's anything else to add.
So the Klintberg article I thought was fascinating, because if I was asked to present a talk on how I would treat shoulder pain, that algorithm is exactly how I think about it. Yet when I actually practice, I don't practice that way. And for all the things that Owen said, I think it's crucial that you get the patient on board, and usually that means providing them with some pain relief on that particular day. So I think that's absolutely crucial as my career has changed. I also agree with him. I don't think we're really strengthening. I don't think the load is high enough for most of the activities I do. I don't think the repetitions are high enough for most of the activities I do to be true strengthening. So there has to be something neural about it. So if you ask me how I go, and the last thing you mentioned was about the goal setting. I've absolutely turned that way as my career has gone along, where I say if we do a modality, you should feel better right afterwards. If it's stretching that's going to make it feel better, you should feel better in 7 to 10 days. If I think it's strengthening or scapular repositioning, you should feel better in 3 to 4 weeks. So in some ways, I think I'm just planting the seed, but also trying to have them be realistic about when the changes should come. So I thought his answer was brilliant on all fronts. I would agree. But the only thing I would add would be, as I think about treating people with non-operative shoulder pain, I think I have 4 different entry points. And entry point 1 would be somebody who is not exactly as the article recommended, but somebody who is very painful, resting pain, you need to decrease their pain. So modalities, maybe joint mobilizations, very rare that would be the case. The second group is a group that can start with some kind of active range of motion. Okay. Third group is they're not near as inflamed, and they can start with posterior shoulder stretching. And then another group that can start with resisted work. So as I think about this diagnosis, it's really where to enter in that treatment algorithm, if you will, based on how inflamed they are.
Well, thank you for that. May I ask you, and the next question is, when do you involve other disciplines like surgeons to work with you? And in your opinion, which pathology are they most useful for?
I may not be the best guy to ask, but I'll try to answer first. So I'm in a building with physicians, and so 90% of our rehabilitation patients come to us directly from the physician, so they've seen the physician first. About 10% of our population can come directly to us. We're in a state where they don't have to see their physician first, but most people still choose that. They want the diagnosis, they want the scan, what have you. So they see our physicians. One of the earlier questions was, do they come over with a diagnosis or do they come over with a diagnosis called shoulder pain? Well, our physicians, if someone's waited for 2 weeks to see them, they're given a diagnosis. It all means shoulder pain to us, but there is something more intelligent, if you will, on the referral, but it all means the same thing to us. When are they most helpful? Again, I'm very lucky in that most of the patients that come to us with this diagnosis have had a subacromial injection, which really, I think, really evens the playing field and makes it very easy. So I'll let Owen answer for somebody that would come directly to therapy and then when to refer into the orthopedic physicians after that.
Okay.
All yours, Owen.
I suppose I most use surgeons and refer on to surgeons for instability patients. I think most people would most physiotherapists would probably agree with that. And I suppose trying to pick out, and this is a much wider conversation, but trying to pick out those patients early who will need to see the surgeon that have a structural instability that is perhaps not going to be responsive to rehabilitation is an art and a science, I think. In terms of other disciplines, I suppose I most often refer on to radiology for guided injections. I think they're the best guys to do injections, really, and even if it's just a subacromial injection, really the importance of hitting the bursa, making sure that the needle's in the bursa is fairly crucial, I think. So if the pain is very uncontrolled, if they are not able to effectively do their rehabilitation exercises, if they can't actively participate or reach the threshold with their exercises that is going to make a difference, then keeping them pain relief with an injection is really important. Rotator cuff repair, I would very rarely go down that route in terms of the population that I see. I suppose my rotator cuff patients are more elderly, and rather than young, fresh, focal tears, it is much more a tendinopathy, tendinosis, progressive degenerative presentation that I see. Rarely would they be particularly suitable for a rotator cuff repair. But the clinical decision making around operation or sort of non-conservative management versus conservative management, I think it's really a very open conversation with the patient and really explaining and outlining the pros and the cons and the risks and benefits of each, and getting them on board with whatever decision they make.
Yeah, all I would add to that is perhaps we should be clear about the group that absolutely should see the physician, which would be somebody who's physiologically young with an acute incident who now suddenly can't lift their arm. For sure, in my opinion, they should see the surgeon. Somebody with a traumatic dislocation, I think they should see the surgeon at least to have a discussion about whether it should be operatively fixed sooner rather than later.
I couldn't agree more. Part 3 is, how do we assess the efficacy of the treatment? And I'm going to ask both Joe Gibson and Chuck to answer these questions for me. What do you think is the optimal frequency and duration of physical therapy to achieve best outcomes?
So I think that's entirely dependent on the type of patient. So, whether you've got somebody with irritable pathology, whether you've got a chronic pathology, whether they're post-op, whether they're sport, the environment you're seeing them in. And I think a lot of that, as well as considering the pathology, is also around the individual, because, increasingly what seems to be most important is our ability, as Owen said, really to educate and engage people and ensure that they're adherent to any sort of exercise intervention. Arguably, those with more irritable acute or post-op pathology, you might want to see sort of more regularly, but in reality I can't see anybody more than once a week anyway, so that's as good as it gets. So unless they're in sports or professional sports, which is slightly different. But I guess that for me, I think a lot of the guys have mentioned this already. In terms of duration, the reality is with most rotator cuff related pathology that's non-traumatic in origin, you'd expect to see a significant difference in 12 weeks. But you would hope to see some change by 6 weeks. Now, I would have to say in my practice, I expect to see it earlier than that. But if we use the evidence to underpin what we do and give patients confidence that time is okay, then the evidence actually gives us quite a big window, because it says that some patients can take 6 weeks before you'll see a significant change. So I think that 12 weeks it's great because it buys you a window, and anything shorter than that is a bonus for the patient. However, having said that, I think the other thing we need to be mindful, particularly with our post-op patients, is if you look at the evidence again, it's very clear that people keep improving after that 6 months, and so they've got greater potential for further gain. But again, I can't treat them forever. So I think, as Owen said, that initial education and engagement and almost empowering them and improving their own self-efficacy is key to minimizing the length of time it takes them to get better, but also to, if you like, infuse and motivate them to keep going with it. Because I think one of the big problems we've got in shoulder pathology is this issue of recurrence, and perhaps that's because we don't get people to buy in long enough to look after that shoulder in the long term, not the short term. So I think, to take from our own experience, if we look at how frequently we looked at a group of patients with what we called at the time subacromial pain syndrome. We can argue about what we call them now, but they were basically in a group, and we sort of looked at 150 patients, and generally the average number of sessions they had was between 4 and 6, but that ranged anywhere from 2 to 12, and some of it related to how long they'd had symptoms beforehand. But what was interesting is if we gave patients the option to choose when they came back, sometimes they wouldn't come back for 2 or 3 weeks because they wanted to get to a stage with their exercises that they felt ready to progress. And I think for us as therapists, that was interesting because we assumed they'd want to see us every week, but actually giving them the right tools and knowing how to control their exercises, they came back when they were ready. So I think that's made us a lot more mindful of talking to the patient the first time we see them in terms of what they buy into. But I would go back to those sort of figures we have from the evidence to give us windows and slack that we're not feeling under pressure to get immediate change.
Joe, just to ask you again, how do you assess the treatment efficacy of shoulder pain patients?
I thought these were some really good questions and some quite difficult questions. I think, no, I'm going to have to be honest about what I really do. Again, it's very much dependent on the environment that I'm working in. I have key things that I measure from an impairment point of view. I like that term that Laurie uses, that impairment point of view, that will guide my intervention. But in terms of the effectiveness of my treatment, it's got to be based in the patient experience and what the patient says. So for me, it's clear, there's 2 key things to that. As I'm going along, I think the measurement of my efficacy is their adherence and understanding, and checking their understanding of what I've told them and that rehab process, as much as it's about, have I made their functional movement better and are they coping better with what they're doing day to day? To measure it in a real sense has to be about the patient and patient reported outcomes, I guess, and a key subjective thing for them. But for me personally, I will have key objective measures. Now, for a sportsman, it might be strength because they like to have numbers, and that could be grip strength or cuff strength in various positions. For my patient in the clinic, I really like the improvement test approach, but I think what's interesting is very simple things like the GERD or thoracic rotation give you a very good measure of whether your exercise intervention's been effective if those things continue to improve over time. But again, I wouldn't say I have 1 or 2 things I do with every patient. It's a question of what's relevant to them. So is it stiff? Is it irritable? Is it weak? Can I change it? And then I'll have key 2 or 3 objective things I can remeasure to ensure my exercise intervention is effective.
The next 2 questions are related. Do you use patient-reported outcome measures? And which clinician-based measures do you think are most helpful full in your.
Okay, so yes, we do use patient-reported outcomes. We're not allowed not to. We have to. And we've used the Quick Dash and the Oxford Shoulder Score historically. The CSP, which is our Chartered Society of Physiotherapists, has imposed the Euroqual EQ5D as a universal measurement both for commissioners, the NHS, the Department of Health. So we had to introduce another measure, which was a bit of a pain. But the issue is looking at anything either retrospectively or prospectively and doing any comparison, we didn't feel we could change because we need that comparison of the measures. And I think the evidence is pretty supportive of the Quick Dash. In terms of representing the patient experience. I'm mindful that Laura's in the room, so I'm not saying much more about it than that. But so those are the two that we use from a patient point of view. Having said that, depending on the patient group, so an instability group, we would swap the Oxford for the Oxford instability. For chronic pain patients, we would also use anxiety and depression and some fear avoidance questionnaires as well. So we definitely use those to measure change. From my perspective, I think it's a great question, actually. Which do I think are most helpful? If I'm honest about what I use day to day, I would dare to mention the word scapular symmetry, which I know is probably a swear word without a fancy laboratory kit. But I think it's fair to say that the evidence would say what I do on intra-tester reliability. So something I feel valid, I will reliably measure every time. It's just that one of my mates is going to have a problem reproducing that. So I definitely use that. I do use thoracic rotation, and again that's probably influenced by the sporting guys that I use, but a common feature of a lot of the patients that I see, and it's a very simple thing to measure. And I do like the GERD, and I think the GERD in the absence of a capsular component, again, I think the evidence supports it's a quite nice measure of fatigue in that posterior cuff and whether it's coping. So they're very simple things that don't require any kit, but the thing we do use as a sort of objective measure is using a handheld dynamometer just for grip strength, because it's dead easy, it's quick, and patients have got a measure, and it's a nice way of them seeing improvement. So I'm grateful for Ian for his paper for giving some validity to that. So thanks, Ian. And they're probably the things that we use most, that I personally use most routinely. But I guess another factor would just be looking at the cuff, not looking at cuff-resisted tests, but looking at can they actually support the weight of their arm and rotate through range. And they're probably the most common objective things I use.
Joe, and the last question, I'm very sorry, it's a very open-ended question. What else should we be doing, and what do you think are the next steps?
In terms of assessing efficacy of treatment?
That's correct.
I think it sort of probably goes back to what I was alluding to. I know it's a very big question. Thanks, Ali, in 2 minutes.
It is. I'm very sorry.
I guess one of my hobby, well, not my hobby horse, it sounds like it's a common theme for all of us at the moment. I think we can talk about objective measures, and we can talk about trying to validate testing and having a consensus of tests that we use. But I think if we look at Rachel Chester's work that's just come out in terms of what are the factors that stop patients getting better, they're very little to do with physical measures. They're much more to do with patient beliefs, patient expectations, whether they exercise regularly, comorbidities, a lot of other things that I haven't mentioned at all in terms of what I remeasure. And that's why I alluded to part of my efficacy is checking the patient's understanding, checking their belief, if you like, in the rehab process and whether or not they can get better, because those things are as predictive or more predictive than anything else I do. So I think going forward, we perhaps need to have better, more consistent ways of measuring beliefs and expectations, and actually looking at how we can influence those with the potential to influence outcome. And there's no doubt that increasingly, I think the evidence also supports that we do need to be looking at ourselves as sort of lifestyle educators as well as exercise prescribers and educators, because so many of the population, particularly in the NHS, lack of physical activity, and as I say, backed up by Rachel's work, it's a bigger pattern, if you like, than just getting their cuff or their neural system desensitized. It's educating them for life, really. So it's a bit of a politician's answer, but I think that wrap round of treatment, we underestimate the massive importance of it. And I love what Owen was saying about that whole engagement, empowerment, educating, explaining. If we don't get that right, anything else I measure probably has limited relevance.
That's a great answer, Joe. Thank you for that. So, Chuck, I'm going to ask you the same questions. Can I ask you, what do you think is the optimal frequency and duration of physical therapy to achieve best outcomes in your practice?
Well, it's not daily. So I realize I'm getting older now, that when I started 20 years ago, it was 3 times a week for 6 weeks. I'm not really sure why. I think it was like an edict or commandments or something happened. I think the reason to see a patient depends on the patient's goals. As Mike alluded to, I think the irritability level of the patient, and then how long it's been since they started to seek care. So sort of the maybe time to care, all in the patient interview drives how often I'm going to see that patient. And then the pathology. And I think sometimes, we're very quote unquote protocol driven in therapy sometimes, and we come up with, oh, well, I follow this protocol or that protocol, and it has a dosage piece in it. But it really comes back to the emphasis on the discussion with the patient and the patient's goals. If I'm seeing a professional athlete who needs to get back to, 100%, anything less than that, they're not going to accept, then it really may be daily. But on the other extreme, if I'm seeing somebody that doesn't have those kind of goals and has different constraints on their life, that's coming to that understanding of how often. So I know that was a complete non-answer, but I think you have to adapt it. And we'll see patients once a week, once a month, based on their irritability, how far along they are in the process and likely to respond. And then how do they respond in that first treatment? Mike alluded to the use of modalities. I would put manual therapy probably in this class of something that allows me to get a buy-in from the patient early to see how they respond. Because if they respond to that early, I'm usually going to see them again relatively soon, ideally 48 to 72 hours to assess, did that response we got early, did that stay? And if it does, now I have some momentum in the treatment and maybe can start to space things out. I think sometimes if I see somebody today and I don't see them again for 2 to 3 weeks, I get concerned about all the things that happens over that course of time to really assess, are the change in symptoms, are they just going to get better anyway? Or is something that I did with my intervention actually influence their change in their symptoms and their impairments?
Thus, coming into the next question, Chuck, is how do you assess the treatment efficacy of in shoulder pain patients?
Patients come to see us usually for 2 reasons. They hurt and they can't do stuff. And depending on stage in life and what their goals are and what they do, it depends on which of those are most important to them. And so relative to that, then usually it's how painful are they? So how irritable and how big is their loss of function? I really like the article that Phil McClure and Lori have, the STAR classification system that was in Physical Therapy Journal last year, really kind of lays out this trichotomy, if you will, of bucketing patients. And I think it sets up nice how that looks. It allows you to set up sort of this broader treatment approach based on their pain. And Mike laid it out very well of entering that. And then those are the things I track is their pain improving? Are their symptoms improving? Or what they can do improve? So I think the single alphanumeric evaluation is a really nice, how's your shoulder, 0 to 100? And I try to do that at least once a week. And then the global rating of change. Are you getting better? Are you getting worse? And how much so? I think are important questions to routinely ask. And I think that gives me some context to say, how is that patient improving? And then I can dig down into the details that Joe hit on of, is it range of motion? Is it strength? Is it whatever impairments that there are, those changing or not? But if the patient's not improving or getting worse, that doesn't give me the context to interpret my impairments that I've been trying to focus on.
Well, thank you for that. That leads to the next question. Do you use patient-reported outcome measures? And which clinician-based measures do you think are most helpful in your practice?
So we do use patient-reported outcome measures, and kind of where I've landed, it's interesting to see the part of the world we live in, how it influences what we do. We use the VR12, which is a version of the SF12 that the veterans and RAN group developed. And basically, it's very similar. It's a quality of life measure similar to EQ-5D. It gives you a physical component and mental component score. And what's really interesting is it in some of the work we've been doing, the mental component score is heavily co-varies or influences the patient's function. So it seems to be quite a bit of influence, maybe more than the physical piece of that score, which is maybe a larger discussion. But I feel like it gives me a sense of how that patient is from an overall sense and how their disability may be impacting their mental state. And then I mentioned the SANE and the GROC on a regular measure, hopefully weekly, that is occurring. And then we use the PIN shoulder score. It has three nice questions on pain, sort of at rest, activities of daily living, and then strenuous activity. What is their pain in each of those? And then a satisfaction, how satisfied are they with their shoulder function? And then it has sort of a standard battery of 20 questions that allows you to sort of see what their functional level is. And I think each of those things gives me meaningful information about how the patient's progressing and what's important to them. On the clinician side, I think it depends on where I started. And so Mike laid out nicely the 4 entry areas. And so if the primary impairment I'm treating is because I think they're a stiff patient, then I'm going to lean heavily on range of motion. That's going to be probably the one thing. I've really gotten where I try to focus on one thing with a patient. Seems to be that's about all they'll do, 3-4 little things. They'll give me 10, 15 minutes a day and focus on one thing. So I usually identify a measure that seems to be the largest impairment and dial in on that and say, this is what I'm measuring. This is what I'm going to look at from a clinician standpoint to see. And then we'll see how that matches with their function, their pain, and their other symptoms. And then if it's muscle function, usually external rotation strength, their ability to kind of complete some side-lying external rotation, more of a functional they can count. Can they do 25 reps with a can of soup or, a bottle of water or something like that for muscle function? And then if it is something maybe more postural or flexibility related, I'll give them a goal and demonstrate that to them. So I think from the clinical impairment side, I usually try to pick the thing that I feel like is most important to the patient and related to their symptoms.
Chuck, that's a really nice answer. Can I now ask you a really open-ended question? What else could or should we be doing? And what, in your opinion, are the next steps in assessing the efficacy of the treatment?
I think as I have come along, I grew up in a biomechanics lab where I would measure everything on 10 patients. And now I measure only a few things on a lot of patients. And I'm very fascinated with what happens as you get large samples of patients, and not 20, 30, but you start getting hundreds and thousands of patients. You can see subgroups. And I think agreeing on some standardization, I think what the European group has done is, while painful, I could sense in Joe's voice that she was a little irritated that somebody was telling her how to choose the outcome measures she had to do with her patients. But I think the beauty of that is it allows for some aggregation of data and collapsing across multiple clinics and multiple experience to see what the effect of that is to dig out. So I think some standardization in outcome collection is crucial. And then that allows us to come up with some maybe common terms of grouping patients. I think we've had some nice discussions both in terms of treatment approaches and diagnostics to put some people in buckets to allow us to compare apples to apples, and realizing that most patients that show up do have shoulder pain, and it's non-specific shoulder pain. And it's unlikely with even the best imaging and stuff we have that we can say, oh, your shoulder's hurting because you have a torn rotator cuff. Like, we have no idea, probably. And so I think with that in mind is coming up with some more common groupings so we can look at the efficacy of our treatments. And then I think understanding that it goes beyond the 12 weeks, 6 months are usually the latest kind of pre-post treatments, understanding what that function is from the time patients sort of in therapy, how compliant are they with maintenance exercises, and what's that influence on long-term function. I think sometimes it says, oh, therapy, there's no difference in therapy and doing nothing at 2 years. Well, what happened between that 90 days of finishing therapy and the 2-year point, what was the patient's functional level? Was my patient who finished therapy out playing golf every day, and the patient that didn't do much over that time? So I think by having standard outcomes and following people over time on a more regular basis gets a sense of the true efficacy and helps us judge on what things we should be doing more of and then what things maybe we can ignore.
Thank you very much, Chuck.
Let's go ahead and open the floor to everybody on this section and as we wrap up. And who would like to share with or contribute to this idea of treatment efficacy and outcomes?
Mike, go for it.
Can I ask a question as the non-outcomes guy in the group? So isn't it difficult, though, when 40% of the patients stop coming to therapy, so you never have a definitive outcome on 40% of the group that's probably gotten better or just stopped coming in? Also, if my group starts with a subacromial injection, their time frame is very short compared to somebody who doesn't. So we talk about standard outcome measures and standard time frames, but even for something that we could probably all agree, no matter what the actual term we put on it, is non-operative shoulder pain. Even for this non-operative shoulder pain, it seems very difficult to capture an endpoint to really get something meaningful. I just think we spend a lot of time collecting a lot of data when we only really need it for a few patients. How I use the patient-reported outcome measures is for the patients that are not improving. Then I start to look at it and say, okay, what's going on? What do I need to do differently?
Lori, can you respond to that?
Of course, of course. I think people are frustrated with, I can't seem to collect outcomes in a meaningful way that I can capture the beginning and the end of treatment. I would argue one thing, you need to collect things more frequently and limit what you're collecting.
It almost has to be every session then. That's the only way to do it.
So I argue with Chuck. I ask a global rating, otherwise known as the SANE. It's the same question, 0 to 100.
Yeah.
I'm at least getting some estimate. And I really like the patient satisfaction question to get an anchor about how satisfied are they on that ranking of function. So I'm at least getting some piece of information so after 3 visits, they don't come back. I think when we do see people for, by and large, probably 8 visits, let's say, some people want to wait till that last visit and say, oh, I'll get the discharge then. The patient doesn't come back. You should be getting that sooner and not just waiting till the last visit. How do you address that, Chuck, in your place?
Yeah, Mike, your assessments are exactly the challenges. But I think what I found is if you don't collect something at the beginning, you don't know how far you've come. You just don't know where you're at. And so, I think what we do is every 6 visits and every 30 days, it's hardwired into our EMR that it has to be collected. And if you can't sign a note and you get yelled at from a supervisor. What it has allowed us to see is, I don't get every patient, but our clinics, we get about 65, 70% discharge outcomes. I have an outcome measure at discharge. And what it allows us to do is now when I look over, I've got about 70,000 patients from last year. It just allows us to look on quite a grand scale of what's actually happening. And granted, the diagnosis is not you, the treatment is not you, it's not, but it allows us to see some really interesting patterns that fall out in terms of the number of visits and who got better. And then I think the next stage for that is using some interactive apps type stuff for an easy way to patients to report how they're doing. So what we're working with is we have a patient app that patients can log on. We push them home exercises, and then they can interact and give us a score, and they fill it out and get it. And that's for us, that'll roll out next year. But I think to date, I send them an email with a REDCap link, and I get 20% of them to feedback. But in that scale, what it allows us to do is, I start with, let's say, 1,000 patients. At the end, I only have 200 that I have 1-year follow-up on, but at least I get a sense of what the longevity of that is. And I think my concern is exactly yours of who got injections and who didn't, and hopefully we can subgroup that. But if I get everybody up front, it gives me the chance to kind of divide those patients up.
I just really want to thank everybody very much for your time and your commitment to doing this podcast and also sharing your clinical reasoning with our membership.
Kelly, Allie, thank you guys for putting it together. Mike, Lori, good to see you guys.
It's
Guys,
nice
you're
meeting everyone.